Okay, I just want to say thank you so much to Dr. Esther Hobson. Thank you for giving us your time. And Esther, you are a senior lecturer in neurology at Sheffield Institute for Translational Neurosciences, Citran at the University of Sheffield, and honorary consultant neurologist, amongst other roles. I'm sure of that. And just say thank you so much for being so willing to talk to us today about NIV4MND. And at this point, is it okay if I just hand over to you, Esther? And then
Yep. So yeah, thanks ever so much, Richard, for inviting me to come to talk. And I'm talking on behalf of my team in Citran and the wider team who completed this NIHR funded study. And I wanted to come to talk to you because I think it's really important that we share the information with the people on the ground that deliver care to all of our MND patients. So I'm going to talk to you today a bit about a couple of aspects of the study that we did, the surveys that we've done with healthcare professionals, and many of you on the call may have completed the survey, in which case thank you ever so much. And then the information toolkit that we have developed on the basis of the survey. And hopefully I'm also going to just give you some ideas to think about your own practice. And there's a couple of sort of questions that I might ask in the middle. And also, if you do want to put any questions in the chat box or comments, feel free, and I'll keep an eye on them, and I'll probably try and answer them at the time that's best, or we can leave them till the end, or I'll stop and answer them. So I'm just trying to work out how I advance the slides. There we are. So anyone that works in MND knows that non-invasive ventilation is the most important and effective treatment for MND. We know that it improves quality of life, makes people feel better, and it also makes them, for many people, live longer. But there's a problem with non-invasive ventilation, and it applies to other things that we do that are complex interventions in MND. A lot of people find NIV difficult to use and adherence rates are low. I'm going to show you some data about that. And in order to get NIV to work, you need to adequately ventilate the patient as well as use it. And often we find there's quite a lot of delays in the journey of patients through the respiratory pathway, and they can become cumulative over time. And we also feel that there's a bit of variation in practice, and not all services are great. And I think funding and knowledge and expertise might be lacking or varying in some areas. So I'm going to talk to you a bit about all of these things. And this is my only sort of statistical equation. And my husband looked at this and he says it doesn't make any sense, so I apologise. But essentially, survival and quality of life in MND, so a happy patient, is equivalent to effective NIV. And effective NIV is basically a combination of good ventilation, so the NIV actually blowing in and out and getting rid of the CO2. And also, in order to do that, you need to actually use your NIV. So you need to actually put it on your face and use it for a period of time. Otherwise, you don't get effective NIV. So those are the two kind of key aspects to NIV that make sure it works. And this is data from DIPALS, which is a study that was led from Citran quite a few years ago, involving quite a lot of the big MND care centres in the UK, and lots of very motivated patients who were felt suitable to have an operation to put diaphragmatic pacing into their diaphragm. And they collected the NIV usage data. And these are the two arms of the study. And what these blobs are is the number of hours per night that the patients were using NIV after initiation. And what you'll see is that some people are using it really well for sort of 12 hours a day, some using it a lot, some 8 hours, which is pretty reasonable. But a substantial number, and 50% of the patients in this study, were using the NIV for less than 4 hours a night. And some were not, a lot were not using it at all. And these are really motivated patients. They're in a clinical trial, and this kind of highlighted that there's a bit of a problem with adherence. And even if you do adhere, so you're using it, you might feel better, it might not actually be doing any good. So this was a study where they took patients who had used the NIV for a month. They took only patients that had said that they were using it all night, and they did an overnight oximetry on them, and they found that their symptoms improved. So their dyspnea or orthopnea improved, their sleep disturbance, morning headaches, all of these things improved. but about 50% of them still hadn't got that correction in hypoventilation that was needed, that was expected of them. And of those patients, if you did adhere and you ventilated well, 75% of them survived to 12 months. But if you weren't effectively ventilating, you only had 43% of them survived. So if you don't correct a nocturnal hypoventilation, that's a month, you really aren't going to give the patients the effective NIV that they need, and they won't live as long and they won't benefit from it, even if they might feel a bit better. So there's a problem with ventilation as well as adherence. And even if people are adhering, and this is a real life patient that we had in a study that I did, a little pilot study, and this is a control patient where we were using the Encore Anywhere telemonitoring and seeing whether we could use it for patients and see whether it would work. And this patient was in the control arm, so we didn't know any of this data at the time. So this patient was given an IV, he had excellent adherence, he felt he was a lot better, he was using it for more than 49 hours a week. And he had good bulbar function, he didn't have much saliva problems, and he was able to independently take the mask on and off. So quite a good candidate for NIV, you'd think. But he actually died quite suddenly during the study, presumably of overnight respiratory failure. And when we went back and looked at the data, we found that a significant number of his nights were spent with a large leak. So he was putting the machine on, but the mask was leaking and it was inadequately ventilating. And I suspect that's probably why he died suddenly. And we sort of missed an opportunity really with him to effectively ensure that he was ventilating. And I suspect if he was, he probably would have lived quite a lot longer. So if you have a think in your minds about what factors might affect adherence, we went away and we did a systematic review and we looked at this. And there are some that you probably are obvious and some that aren't perhaps quite so obvious. So these are the sorts of things that can affect how much time people are actually using NIV. And so bulbar weakness is probably obvious. Excessive saliva, that has a big impact on NIV usage. Poor hand function, claustrophobia. And then a recent study I found fits in with what we suspected, which was social factors are really important. So these people that are unmarried, lower income, lower educational attainment, and limited carer ability are all less likely to use NIV and gain that benefit. However, there are things that can help. So you can adjust the ventilator settings, and that's been shown to be effective. Our qualitative study found that if the patients feel the benefit, then they're more likely to continue to use it. And also just attendance at an MND care centre can increase the likelihood of NIV usage and adherence. And so just being around people like yourselves who know a bit about NIV and MND and perhaps encouragement has got a positive impact on adherence. So you are really doing a really great job. So knowing all of this, that there are these problems, we thought we'd have an understanding of what was going on, the best way to provide NIV services in the UK, and how we might improve services and how we might disseminate that information. So we gathered all the evidence together. We really put it into context by involving healthcare professionals, and we wanted to then translate that into some resources. And we did that in a few ways. We did a systematic review, looking at all the evidence and pulling it all together. We then went out and we surveyed loads of people in the UK. So we had 55 replies from all of the MND care centres in the UK, from a nurse or a care coordinator at each centre. We surveyed 158 people who were involved in MND care, either because they were a respiratory clinician or they were a community member of staff or worked in a hospice. And we had a large number of people from all over the UK provide responses. We then took all that information and we presented it to people in 5 focus groups, and we got 30 healthcare professionals and some people from the MNDA together to sit round to really tell us, what does this information mean? And then we developed our educational toolkit. So I'm just going to present a few of the key results from our survey that I thought you might find interesting. And what I would say is that this is sort of what people told us. It might not necessarily be all and completely accurate, or it might vary depending on individual practice. So we just generally ask people, in general, what do you do? Or in general, what does your service do? So one of the sort of key themes I'm going to talk about is this delay in the pathway. So if you think a patient has symptoms, they get a diagnosis, and particularly during COVID, we all know that patients have had a delay in receiving a diagnosis. They then might start some respiratory monitoring. They might get a referral to a specialist. They might be diagnosed with respiratory insufficiency. They might start to be prepared for NIV. Then they might start the NIV, and then they might be reviewed again and adjusted, and then eventually they get established on NIV. And these are lots and lots of different steps, and it's quite helpful to sort of think about each different step in your own pathway to make sure that we are kind of getting to that point at the right time for the patients without too much delay, but also with enough time to prepare the patient and the carer for the eventual, use of NIV. So we asked a few questions about respiratory monitoring because we knew that probably varied, and what we found is that lots of people are using forced vital capacity to monitor their patients. Quite a lot of people have access to home oximetry. We also found people were using other things like peak cough flow, perhaps not so much, and SNP, again, not so much, although actually there is evidence now that SNP is probably more sensitive than FVC at detecting early respiratory failure. So that's something you might want to think about in your own practice, although SNP is it's not a very nice thing to do, and you can kind of see why people don't do it. Blood gases, about 70% of people using daytime blood gases, which I think is again more sensitive than FVC. And people were using daytime pulse oximetry, which is mentioned in the NICE guidelines, but really isn't very sensitive to early or even moderate respiratory failure. By the time you've got low daytime saturations, you really are in trouble. Some people had access to these more complex devices, like polysomnography. But what I would say is, thinking about our pathway and the need for avoidance of delay, is that if it takes you some time to arrange polysomnography, then that might not actually be in the patient's best interests, because you might be better off just getting on and preparing them for NIV, because you don't want to delay patients who really do need to start it. We also asked them sort of what criteria do you use? What's in a typical patient with either symptoms of respiratory insufficiency or without symptoms, what are you using? And so most people are looking at forced vital capacities of around 70% of what the predicted is, with 100% being normal. But there was quite a range, and some people were looking, mentioned 50% being the sort of cutoff for when they'd really be starting to think about NIV. Some people 40% for people with symptoms, and that's actually quite low, I think. I think that if by the time you get to that sort of stage, then you really ought to be thinking quite seriously about NIV, or at least doing some additional testing. SNP was a little bit more consistent, with sort of more consistent results. But these had roughly adhered to the NICE guidelines and roughly adhered to evidence as well. So this sort of brings me back to this sort of business about the delays in the pathway being cumulative. If you're deciding that you're going to either use an insensitive measure like pulse oximetry, you might miss people who are in respiratory failure. Similarly, if you need to go and do a specialist test like a polysomnography, you might delay this a little bit further. So in your patients, if you have a think about how long does it actually take, if you're having the feeling that patient might be in respiratory failure, or even they don't have any symptoms at all, what's the delay between that and them seeing someone who can actually do one of those sensitive tests? And I actually want to suggest that we move this bit patient preparation right back up the pathway, and so that people are being prepared much earlier for NIV. And that comes to sort of, when do we talk about NIV? And so we ask people typically what time, and when you're seeing a patient in clinic, do you talk about NIV? Actually, some people said that they do talk about NIV right at the point of diagnosis, although the most common time was around after diagnosis, but before the onset of respiratory signs and symptoms. So that gives you, ideally, unless the patient presents urgently, lots of time to prepare the patient for NIV. So some people were talking about talking when they start to have a decline in lung function, or they develop signs and symptoms. But there were people that really started to talk about NIV at the onset of respiratory failure, which might arguably be a bit too late really on the average patient, because by this point you don't have time to do all those things that we need to do about thinking about adherence, thinking about carer preparation, optimizing symptoms and secretion management before you actually start thinking about the mask. So actually it's reassuring that people are thinking about this really early. But again, we do need to be consistent with that and continue to have the time and space to do that. And what do we talk about? So we asked the MND care team what they talked about, and we asked the ventilation teams what do they talk about when they before or at the time when you're thinking about NIV. And the what I found, so the black line at the top is what the ventilation teams talk about, and they seem to cover most things. And there's this sort of difference between the kind of like what NIV is and the broad understanding of it and the benefits and things. And the MND teams tend to cover that, most of them themselves, but they're less likely to cover some of the more practical aspects of NIV, like wearing the mask. And I think I've moved on, I've sort of highlighted those. I think what was interesting is from this one is that not many of the MND care team talk about the impact of NIV on carers and family members. And it reminded me of a finding from my own PhD where I interviewed carers, and one of them said, I'm just treated like another piece of equipment. And she sort of just said, well, just everyone just assumed that I would take on this role and look after this person's NIV. And the new MNDA audit has a section asking about the involvement of carers in the respiratory care pathway. So it's something for us all to think about. It's about, asking about carers, because we know that people who have poor social circumstances don't adhere very well. And also it's just going to be really important to involve carers. So have a think about that within your own unit, about how you do that. And then also for the MNDA audit, the next time it comes around, how you document that so that you can tick your box on the audit. So I thought it was interesting that was more something that was really discussed by the respiratory team. I suppose if you don't feel confident to discuss that, maybe have a think about the sort of things that your carers that you could communicate to carers, even if it isn't the practicalities of actually using the mask. It might be about, are you going to be available? Who's going to be around at night? Do you need some help with this? All of those sort of things. Do you need a carer's assessment? And interestingly, I thought that actually it was usually the respiratory team that thought about secretion management, whereas often medications might come from the MND care team side of things, but they tended to talk less about symptom secretion management. Maybe that's because respiratory team use a lot more cough assist. We also asked them about when they refer people to a respiratory service, because whilst some people kind of co-located their services together, so they saw people in the same clinic or in the same building, a lot of times you needed to refer patients to the respiratory service, either formally or informally. And about 40% of people are referring their patients immediately at diagnosis, and most of those that did thought that was the right time. And about 40% of people are referring patients when they develop signs and symptoms. And remember that, by that point, most people have actually started to talk about NIV. And so hopefully those discussions are being made within the MND Care Centre, but a lot of people aren't actually seeing a respiratory service formally until the point at which they develop symptoms. Quite worryingly, some services were referring at the point of respiratory failure rather than beforehand, and you might argue that means the patients haven't got as good a chance to prepare for the use of NIV. And quite worryingly, about a third of respiratory service healthcare professionals felt that the referral occurred late. So this is one sort of free text thing I think came from the focus group of one of the consultants that said, referral to us is late in the course of the condition, and sometimes the diagnosis is made late. That's understandable, but frequently I think it was really interesting that they thought that it was distressing to patients to talk about NIV, so the referring teams hold off as long as possible until symptoms develop. So perhaps we need to practice, and the only way to talk about difficult things is to practice talking about them more, is to talk about these things earlier with patients to enable it to be a bit more of a smoother transition to respiratory services, or simply just make it part of routine care. So we also asked how long it took to start NIV in your service. And actually, in most of the times, if it's an urgent referral, so these are patients that need to be seen quickly because their CO2 is raised or they're in significant respiratory failure, usually they could be seen quickly within a week or within 2 weeks. But there are some services that are taking 3 or 4 weeks for patients to be seen. And there is evidence that people could die within that time, or at least become severely unwell, and maybe NIV is then not useful for them. And some patients, even for non-urgent referrals, are waiting 3 months to be seen in a respiratory unit. And again, some are waiting 2 to 4 weeks to then commence NIV once they've been seen. So if you can imagine you see a patient and you're making a non-urgent referral, it takes 12 weeks, and then you need another 2 to 4 weeks to start the NIV process. It could be quite a long time before patients are actually being initiated and then ineffectively ventilated as well. And I think these, whilst people talk about what they think is going on, I think it's good to think in your service, how long does each patient actually wait from decision that it probably needs NIV to actually starting on it? Because it only takes the person to be on holiday for a week, and that's another delay, isn't it? So one of the key positive messages I thought was this study that we came across, which was really interesting and sort of an accidental research finding, which was quite good, was that an Australian team, they switched from an inpatient model to a day case admission, and they were just doing it as a pilot study. And what they found was that day case admissions rather than inpatients, it sped up the process of the time waiting to start NIV quite a lot. It didn't affect effectiveness at all, so they were still effectively ventilating, even though they weren't being started in hospital. And also what they didn't expect was that survival was better in the patients being admitted to a day unit rather than inpatients, because quite a lot of people were actually dying just waiting to come to hospital to get their NIV. So it reminds us that we need to if we decide we need to start patients on NIV, we do need to start it pretty quickly. So this another respiratory consultant said, they have a domiciliary setup and it can be done within a week. And this avoids, no one wants to come to hospital at the moment. So it's a good way to do it. And if you haven't got this sort of option within your service, we'd be happy to share this information with your managers to kind of really support this as an expanding service. So yeah, we asked people where they can set up services, and most of them did have sort of an option for outpatient initiation. Some people did have the option of multi-night admissions, and sorry, that's really bad timing. Oh, go away. So most people had the option to admit patients, although, there's often a conflict between that and say, your urgent lung cancer patients or your urgent stroke patients. So that's a challenge, unless you've got a really well-funded service, I think it is quite challenging to do that really responsively. But people sometimes chose one-night admissions or day case, and then about 65% had domiciliary initiation, but a lot of those people weren't really funded for it. So I suspect these are people that are sort of dashing out in their own cars, probably in their own time, paying for their own petrol, some of them, which really should, and I think domiciliary initiation can be quite effective. And when we ask people, I think most people either preferred it to be outpatients or patients' homes for initiation. So I think that's really the way forward. So once you've initiated a patient, you've then got to make sure that they are followed up. And the sorts of things that you're going to be checking on are going to be adherence and ventilation. And so we asked people when they first made contact. And bearing in mind that study I mentioned at the start, where about half of the people at 1 month were using the NIV, but they weren't effectively ventilating. So the first contact was usually about 2.5 weeks, but it sort of varied in the interquartile range, which is about 75% of people was in 1 to 4 weeks. And then again, sort of around 8 weeks and then 12 weeks. And then they sort of went to routine monitoring every 12 weeks, which was pretty standard. And then I just sort of wanted to have a think about what the sort of things that you might look out for. And I think what this suggests to me is that perhaps we haven't got really good funding to follow people up quite quickly, particularly those that need it, that need to get established on it. They need to get feeling like the benefits happening, that they've got saliva problems are being dealt with, social issues, the care is being supported. So actually leaving them 2.5 weeks to first contact might be actually quite a long time. But I suspect that the reason people are doing that is because they just haven't got the staff to do it any quicker. But I thought there might be a role for the non-specialist teams here. So if you're going in to see a patient who's just been initiated on non-invasive ventilation, I've not even put in some answers there. You might be wanting to feed back to the NIV staff or the MND care centre about some of the aspects that we talked about earlier, such as saliva control, what their bulbar function's doing, how the carer is. Are they fighting? Are they stressed? Are they moved out? Have they got someone at night? Can they take the mask on and off themselves? Are they having difficulty with the straps? And that will obviously change as the patient changes. And so the patients kind of sometimes they think we've got CCTV in their homes and we can tell what they're up to, and they can tell when they've got a problem, and we'll instantly be knocking on the door and checking on them, when in fact the respiratory physio is probably not going to know if the patient's getting worsening hand grip. So that might be something that we might need to feed back to them to try to get them something adjusted with their mask, or think about a way to get it off, or emergency call bell, so that they can feel confident that they can go to bed at night and not have a problem in the night. And also, you know, the ways that the staff need to adjust the ventilation settings, make sure people have got adequate tidal volume, avoid the situation like I mentioned at the start where we didn't realise the patient had large leaks. This all needs contact with the patients. So how do people monitor that at the moment? Well, quite a lot of people are still just monitoring by asking the patients, either both for ventilation and for adherence. And about 66% of people use machine downloads from the NIV, and about a third are using telemonitoring, which in my opinion is probably the way forward. And again, for ventilation, it's about a third of people use telemonitoring, and some people are using polysomnography, so doing formal testing to see how effective it is. But definitely, I think there's if you're not using things like machine downloads and telemonitoring, then again, it's something we can perhaps share our experience and try to support increasing support for staff and funding for that sort of thing. I think that's going to be really important to make sure people do effectively ventilate. And so that sort of leads me back to my point about the delays in the pathway being cumulative. If we're not sort of monitoring people and making sure they're established, we're going to miss out on those patients who might feel some benefit, might be using it, but are inadequately ventilating. We also asked about equipment, because the focus groups definitely said that every patient's individual and they all need lots of different options and tweaking. And so actually, most people could give the patients a battery, so they could leave. No, that's not a battery. What is that? That's a machine. Most patients could give one machine, and a lot of people gave two as the maximum. Some people had more than two, but funding was often limited for machines. And thinking about masks, the standard amount people could get was two, but some people could only get one. Some services, the maximum they could really get for a patient is two, but some services could get 12. So there are options out there available for services to have more masks, so people can have a different mask depending on the needs that they have. Again, batteries are really important. It's in the NICE guidance to get batteries. So the patient, if it's in the NICE guidance, the patients have a right to it. So most people could get one battery, but some people could get two, but at least most patients could actually leave the house with a battery. It brings me also back to a point made by one of the respiratory nurses in America, who said that a lot of her patients who ended up with an emergency trachea, the reason for that was they were leaving the house without their equipment, having a sudden respiratory deterioration outside the house and ending up in the emergency room. Oh, I'll come to telemonitoring in a minute. Yeah. So the patients were going to the emergency room, not getting their NIV because they didn't have them with it, and they were ending up being ventilated, intubated and ventilated for a respiratory crisis. So it's really important that patients realise if they are needing NIV, that they need to go out with it, so that if they do have a respiratory problem, they have available their equipment. And patients look at you quite surprised when you say, I say, they're not going to have an NIV system in A&E, and they're like, what? You say, well, no, you need to bring your own equipment with you, so that if you have a problem, you put it on whilst you're waiting for the ambulance or you're thinking about what to do. So things like batteries are really important, and the additional machines. Again, humidifiers can be really helpful for patients, but a lot of people, most people were able to access one or two humidifiers, which is reassuring. Oh, Katrina's asking about telemonitoring. So what telemonitoring is you can put a modem on the back of some of these machines, and it sends you the data, and you can see how long people have been adhering to it, so how many hours overnight they've used it, and it also tells you what your tidal volumes are and whether there is any leaks on the mask. And so that can help you to decide whether or not they're actually ventilating in and out, and whether there are any mask leaks. And then you can also adjust the settings remotely, so you can phone the patients up and they press a button and you can adjust, you can increase the pressures, or you can send them out a new mask, and then you can have another look the next day. It also means you can look without actually having to call the patient, which again sort of saves you time. Otherwise, you have to send the little cards back from the machines in the post, and that causes delay. And if you're trying to monitor people a week after they've started NIV, it's going to be too late because they might have given up by that point and think it's rubbish. So hopefully that explains what telemonitoring is. Funding's still a real problem because we found that only 20 services were able to provide 2 NIV machines, 1 battery pack, 2 masks per year, and a humidifier. So a lot of services are not getting the funding for what I think is really needed, and the NICE guidance are suggesting that patients need. And some services said there was no machines at all were funded, and having to go to charities to get NIV machines, which again is against the NICE guidance, and the patients do have a right to access this. 8 services had no funding for battery packs, 3 had no funding for masks, and 4 had no funding for humidifiers. So I think if you are having problems with funding for these basic things, perhaps we should discuss that as a community, involve the MNDA, and try to really support people in getting funding for this, what I think is a basic standard of care for patients. And then we asked people what they wanted to learn more about, and people were interested in most things, the early stages of the pathway, but particularly about monitoring and optimisation of NIV and withdrawal. And so then what we did is we went and did lots of focus groups and talked to some people to try to explain some of those findings that we had, contextualise them and put them into sort of real life practical guidance. And we found all sorts of things that people needed to do and what good practice should look like, and we put that all together and we made a website. Now, we've already got these patient-facing websites that hopefully you're aware of, that you can give to your patients and carers to look at about NIV, cough assist, and feeding tubes. And so we kind of use that sort of approach to develop a healthcare professional-facing one, and it's called NIV4MND. And this is what it looks like. And it's now available, so you can type in NIV4MND.co.uk and it will take you to our site. And it's got a search function, it's got images, videos, and it breaks it down into the different stages of the pathway. And that means that if you know loads about respiratory function monitoring, you don't have to go through all of that. You can go and look straight at, say, withdrawal of NIV, if you're going to go and see a patient that day who you're thinking about withdrawing, and you can go through those steps. It's got videos from people like me and Chris, which are pretty useless, because it's got really useful videos from real experts like Debbie from Salford and Matt from Sheffield, who are very experienced respiratory physios, who you can give lots of their own real practical information. And it's got information from patients as well, and I think they're the most useful because they've got really good the way they describe the problems that they have and the way that NIV has helped them is much more useful than me explaining that to a patient. So it gives you some ideas about how you can talk to a patient and explain it in a way they'll understand. So it's got sort of real practical tips. And so if you don't know much about MND or NIV, you can start with some of the signs and symptoms, things you need to look out for. It's got loads of videos, and these are sort of more practical things. You might be thinking about how to deal with poor tolerance. You might, if your patients think you're going to think about withdrawal, you might just want to watch some of these videos talking about approaching withdrawal from different professional aspects. And also there's some fantastic videos, quite powerful ones, of Julie, one of our patients who made the decision to withdraw from NIV, and she discusses this with her son and how they came about the decision. And again, I think that I really recommend having a look at some of that, because I think it's really powerful and helpful for us to understand the decision-making process. And looking after people with MND is hard, and it can be quite intimidating, particularly if you're not familiar with it or if you're having a hard patient. And we've also got some videos from our psychologist talking about the psychological aspects of MND, and also how to look after yourself and deal with your own sort of frustrations or difficulties. It's got some really sort of basic things that you might recommend to someone in a nursing home to have a look at. So, your care manager of the nursing home might be able to help you with skincare if they've got a lot of problems with saliva, or how remind about using an oral suction machine. There's even hypnosis can be effective, and it might be something that you can explore through your hospice services. And it's got some reflective bits as well that can question your own knowledge, and then it could guide you to further aspects of the website. We'd like to make this into like a CPD thing where you can register and get points, and if we get a lot of positive feedback, we can look into that. It's also got lots of resources as well. So the guidelines, it's got guidance from MND care centres have got their own guidance, and we've put some of those in because you might want to use those for yourself. And it's got MNDA guidance, some patient leaflets as well. And we have done a little bit of evaluation of this, and we found that it's people think it's useful, and people would recommend it to other people, even if they're experts, they wouldn't use it themselves. So please share the website with people you think might be useful, particularly your new team members, community staff that might not know much about NIV, inpatient, your nurses on the inpatient wards who look after people, new hospice teams, your peripheral staff. So, you know, your physio, your psychologists who might never have seen a machine before, junior doctors. If a patient's going to a nursing home, it might be good for the nursing home staff to watch the website and sort of see some of the things in progress. So please do share it with other people. And thanks, Aria, for saying the website looks brilliant. Thanks for sharing it. Well, yes, so do share it around, because it's only going to be useful if people have a look at it and use it and maybe give us some feedback. So in conclusion, I think that NIV services do vary across the country, and there's some evidence of some really fantastic practice going on out there. And the people that, you know, we saw from Jodie's presentation last time that there's loads of work in this area that's really inspiring, and I think we can all improve our services, and how important the simple stuff is. So, you know, if it's just a community member of staff feeding back that a patient's struggling to use the mask, or they've fallen out with their carer who's moved out and now they can't use it, that's just really key to making sure that patients effectively ventilate. And can you improve your service? Could you do a mini audit to have a look at how things are actually working for the patients? How can we support each other to improve our services? And how can we learn from each other? Because really, to make a good change, you have to be able to do it and motivated, but you also have to have the support and the opportunities. So yeah, if you do look at the website, please send me some feedback. I'm really interested. I can log in anytime and change it. And the final thing is a massive plug, that you're welcome to come and join us in our Sheffield MND Care and Research Centre. And we actually have 2 fully funded clinician PhDs at band 6 or 7 for healthcare professionals to start working with us. So speech therapists, physios, nurses, to come to spend 3.5 years doing a PhD working on a clinical project with us, something similar to this. And you might help us with our £50 million sort of aim to cure MND, and in the meantime just make it better for people that have to live with it. Can I put the website address back up, please? Yes, I can. I can type it into the chat box for MND. Okay, there we are. So yes, if anyone's interested in coming and doing a project like we've done already, then do get in touch, as these are fantastic opportunities for healthcare professionals to come and make our service and our research even better. And so just thanks everyone. If any of you completed the survey, we were really grateful if you came to the focus group, because that made a huge difference. And I've got happy to answer any questions or have a discussion if anyone's got any thoughts or things. I might put back up is that one.
That was fab. Thank you. Any questions? Wow, that website is brilliant. I have to say, I actually really like the website because it's not just about the professionals, it's also the people. It's also, you get kind of the full rounded kind of version of events.
Yeah, I think the My Breathing one that was initially made is so powerful, and I found it useful to talk, and I can talk about specific patients with my patients because their stories are on the website, and just having some of those is really useful. Anita's got her hand up.
Yes, thank you. Thank you very much, Esther, for that. It was really helpful. and it's got me reflecting on our services and the respiratory care. I'm a respiratory and neurology physio from the community perspective of things, and we have a population of 500,000 with 66 patients of MND, and we started doing timely sort of monitoring of tests, respiratory tests in the community in 2014, and what we see is that we are getting timely ventilation into the community quite quickly, and supporting and collaborating with the 5 services our patients filter into, which is a bit of a minefield. What I noticed on your one of your slides, looking at the impact on patients and carers with NIV, because obviously we know that it, apart from improving quality of life, it does prolong life. And I've got about 5 patients who on NIV 24 hours for the last 3 years, and it's also the impact on staff. And because they've developed further complex symptoms, and managing that in the community with varied skills is a real challenge. And I'm wondering whether there's any offtake from that, or papers or anything that came up in your study.
Yeah, I think you're right, it is challenging. And I think, so we've done some qualitative papers looking at patients and carers before and after death. And certainly the message coming from carers is how traumatic it is to look after someone who is very dependent on NIV, and also the sort of fear that people coming into the home are not confident to look after NIV. So one of our PPI, so the sort of advisors on this study said someone unplugged the ventilator for her son, who was 24-hour dependent on NIV. And obviously after that, he just didn't want anyone else in the house. So she's so traumatized by this experience that I think even, people having even the people that are just maybe the carers, professional carers going in, could have a look at this website just before they go, so they're not quite so frightened by NIV. And in fact, we might sort of add a little bit more about basic information. We might steer them even to the patient site, which is My Breathing, that gives them sort of ideas about that. There is some, so the psychologist has got a couple of videos on the site about how to look after yourselves, and she's offering us debriefs, sort of some support, staff support, maybe getting together, and particularly in COVID where you don't see people, do you? Just trying to support each other. The other thing that is in development, and we're working with the team in Norfolk and Norwich about a toolkit for carers for people who have frontotemporal dementia-like symptoms, even mild symptoms, because I think, as you say, by the time the patients are getting very dependent, then if they have got any of these symptoms like impatience or frustration, they just get worse and worse because they can't move, they can't call out. And that toolkit that's in development, and that might be helpful for carers and for staff to help them accept the behaviours that they've got and learn that they're not the person, they're the disease, and how to just protect themselves. So I think you're totally right. It's a really tough, thing to do, particularly if you don't have the kind of contact with lots of staff all at the same time that you can share this burden with. But yeah, certainly have a look on the first section, because our psychologist has been really, the videos I found were really helpful.
I think what we are highlighting with commissioners is that the impact also is that the expertise often sits in the acute sector or tertiary. So we're trying to work now to try and sort of convince and work with commissioners to upskill and to bring more expertise in the community, where patients like these who are housebound on 24-hour ventilation, the expertise needs to sit in the community. So having to upskill and put more funding into upskilling in the community.
Yeah. So we've got a podcast that I've not put on the website yet, that where we interviewed a community nurse who has upskilled a hospice or several hospices and networks in this area. And so I'll try and find that and get it up on the website, so you can have a listen to the sort of ways that she's gone into services to try to help with this. But you need the space and the time, don't you, to to come together, to debrief, to share your experiences, to support each other. It's really tough, isn't it?
Yes, I think so. But I think with as technology gets better, timely diagnostics coming into the community, we are going to see more and more patients getting timely NIV, and that's good because from that side of the pathway. But on the other side is that then we have patients who are a higher population of patients living in the community with an NIV, with only a few of us with the skills, and we need to really populate that across and make it more mainstream to a certain extent. And I think that's the challenge that we are facing. We have started up some forums to work on that and bring in expertise that way. But it is the challenge that we are looking at the timely interventions, but not looking at the matching it with the skills in the community.
I guess it's why these sort of forums are really great, aren't they? Because you can share that sort of knowledge with other people on the call who are exactly the same position.
Yeah. Thank you very much.
Thanks. So people have asked, is NIV4MND for patients? So we've got the sister site, which I'll just type into the chat, called My Breathing. In fact, if you go on the NIV site, it asks you whether or not you're a patient or a healthcare professional, and it will take you to the right site. So the My Breathing one is more for patients and carers. And I think actually informal carers might find it useful as well. So I would probably direct them to that one. The NIV4MND site is available to carers, like it's open and freely available, so anyone could look at it. Do I have any leaflets that could give? We used to have some, but we used to have business cards actually, but I just tend to write it on a piece of paper now. But if you go, yes, if you use that website, that's probably the best way to find it.
Right.
Jodie?
Hi, Esther. I'm going slightly off piece, but I guess picking up a little bit on what Anita's just said about the skill set in the community, not necessarily NIV related, but I was just have a little look through your excellent NIV4MND website. I'm just wondering, one of the current and probably ongoing challenges that we haven't overcome in our area is the suction issue. And procuring machines, but then once we've procured a machine by hook or by crook, is AHPs or people feeling confident and competent to train carers or patients themselves to suction, and everyone seems to shy away from it. So us as a tertiary centre are trying to do as much as we can pragmatically. I was just thinking about your website and whether you guys would consider, I can see you're hosting the information leaflet from the MND, and would you consider using your website as a kind of a training tool, like video-based training tool for those sorts of things as well for AHPs and professionals, or do you think that's a bit too far?
I think that's a really good idea, and I wouldn't have a problem with. I can put any web video on this website as long as it's I think if it's all of them are done by professionals. It's clear from the videos and things that they're all people who are competent to explain something like that. So suction isn't something we haven't got a huge amount on cough assist either, because it was sort of focusing on NIV at the time. But these things, it's so important to get the patient ready that actually having that. The other thing is persuading staff to provide things like glycopyrrolate, which is effective in NIV and in the NICE guidance, but you're having to say why you haven't given something else, and that delays it by 2 weeks, and during that time the patient's got loads of saliva, you can't get NIV started. So maybe we should have a discussion of this, and we could perhaps get a video up there and get that, and there's certainly
that would help us out as well if you're able to host that, and we can help. But it feels sometimes that leap to NIV can just feel a bit, it's like another step further when we haven't got the basics right with the saliva management and things. So that'd be great.
Again, if anyone else has got like things that they want to put on this, then I think that the more sort of professional led this is, the better. And again, if you can then direct people to this, that would be great. So they have a small stock of suction units for loans. I'll put that on. I'll add that to. I'll make a suction page, which I don't think we've got. No, we've got optimization of cough and optimization of oral secretions, and I'll just have a quick look. It doesn't have much about suction, so I'll add that, and we'll may make a new page, and we can put that on. Can you share my email address again? Yep, I'll put it in the chat. Yeah. So we've got that there. We may need to have some more. I think we filmed our videos during COVID, so we may need to have some more sort of more practical videos on there, and we can certainly do that. It is about getting the. We need feedback now to really understand where, you know, whether this is too basic or too complex. We did talk about having like a prescription for NIV, like, you know, you start at this pressure and you go to this pressure, but the staff in the focus groups felt that you couldn't do that because patients are very individual and they need to be, you know, need to be done by someone who knows how to adjust it for individual settings and things. But certainly something like suction, you know, I think there's a reason, you know, that's pretty safe, and as long as we can get a nice video, I'm sure that would be fine. Similarly, we could potentially look at exploring putting a cough assist video in as well, if we think that that's something that could be, even if it's just to remind you if you've not used cough assist for a while. Yeah, it's crazy, isn't it? So you could use cough assist, but no one was able to use oral suction. I mean, do you even need training? You just turn it on, don't you? I mean, yeah, and it's a really big barrier. It is, particularly if they're sourced from different, because I don't know where you source your suction machines from. They're all sourced in different places, aren't they? So you often, I think you need to get them from, we need to get them, I think, from district nurses, which is obviously different from the cough assist, which is different from the NIV, which is different from the nebulizer. I think if anyone, so certainly in the survey, if anyone does have any issues about accessing any of this equipment or time, do get in touch, because I'd be quite keen to help people to make sure that everyone in the UK gets at least the basic level of NIV service. And perhaps we could then sort of have a discussion about how to support people doing that. Jodie said the MNDA info leaflet is useful. Procurement, yeah, the video would be good, so we could put the video and the leaflet together on the website, so you could find that and send. And as I say, it's accessible, so anyone can look at the website. GP can be reassured that they're not completely going off course by prescribing glycopyrrolate, or the nurse could know that the suction machine, they could review that before they went in to see the patient if they'd not used one for a while.
Any more for any more? Gosh, it's already 5 to 3. Isn't that amazing? It just went.
Yeah.
That was so great. Any more comments, reflections from anybody? Well, I just want to say thank you, Esther, for your time. And I think that we should all switch our cameras off and give you a clap. So I'm going to do that. So please switch your cameras on, and I'm going to give you a clap anyway. So thank you.
Well, thank you very much. That's very kind. Thanks for inviting me, and again, thanks for organising these sessions. They're great, and hopefully I can meet some of you in real life at some point in the future.
Yes, absolutely. Great. All right, and thank you everybody for attending. And this is recorded, so I shall make that available. And yeah, have a lovely Thursday afternoon.
Great. Bye-bye.
Bye-bye.